And I just welcome all of them now for our last and final discussion time. I think I will start off with just a question to the entire group. We talk a lot about technology today and various uses of it, and with Dr. Zavulis talking about some of the 3D printing, simulation. Just the first question is, who here actually uses that during their everyday planning for an operation?
I suspect many of us use, 3D reconstructions, of course, but not necessarily, we aren't using 3D printing.
We're using it as part of the research protocol, but to be realistic, and especially with a lot of other ongoing limitations that we have, current practice with COVID and a lot of the challenges in the setting here, it's not always as easy. And the question is always on the mind whether how much of a difference does it make compared to an experienced surgeon. And that's the same thing when they were trying different resection techniques and instruments, and they saw that it does not always make a huge difference.
I've had some experience with Pathfinder. I think it's actually a very interesting technology, but I think, like everyone says, vast majority of resections, whether HCC or any other types of tumors, I don't think I really need it just by studying the preoperative imaging. I think it's just figuring out which of those cases is it really going to be beneficial. I think more interesting is real-time sort of feedback or sort of the augmented reality, as you had mentioned, being able to see as you're going through the liver or planning for it, rather than preoperative.
I agree. I think
may just say a word of support to Mrs. Winslow. This is a lot of work. So, and probably it's work done before the patient comes to the surgeon. So that's, but I think this is, of course, very extensive work, and this is half-bred for radiologists, not for surgeons, for radiologists, because they, as you said, they don't do that. They don't do their homework. I'm sorry, but I have to say that. So congratulations for that huge amount of work. And I think it would be really very helpful if the radiologists will use that and really would use that and look at your textbook. This is my opinion. So congratulations for that. I just want to ask a question to both Dr. Bean and Dr. Winslow. What about the lymph nodes of the hilus of the liver? So you don't care? All the surgeons don't care about lymph nodes? I mean, all these patients have enlarged lymph nodes in the hilus. So you don't care about that?
Are you talking about as a quality metric? Is that? I think, I mean, in terms of the imaging based thing, I think that there is a feature that's described as concern for systemic disease, where certainly enlarged lymph nodes are part of it. But the problem, of course, is that, most of the patients with underlying liver disease will have lymphadenopathy that's non-malignant. And so, but on the pathology portion, whether that's should be part of our optimal surgery, I think I'll let Joel answer that.
Yeah, so ACS NISQIP doesn't collect data on lymph node harvest. So, it's tough to include pathologic variables in these optimal composite outcomes. So that was one of the limitations of the study I presented from the ACS NISQIP study. However, the study by Dr. Pollack and the group here at Ohio State that I kind of presented at the end there, they did include things like pathologic variables, including an R0 resection. And they found that there wasn't a significant drop-off in their textbook outcome measure. But yeah, lymph nodes would be great to incorporate in future studies, and I think it's important.
So as far as I know, this is the only tumor whether you don't care about lymph nodes, right? I mean, taking all the tumors you may operate on, even pancreas, where you don't care much, but you should care. But liver cancer is. I mean, you presented data, Dr. Bean, on intracellular cholangiocarcinoma. You have at least 10% less survival compared to HCC. So what is the reason for that? We don't know.
Yeah, I mean, it goes back to tumor biology, essentially. These tend to be historically more aggressive, but yeah, why exactly, it's hard to know.
It's a question for the future, for hepatoma research.
Yeah. There's actually, I want to ask a question from the chat. I think one of the questions one of the participants have asked is, how do the surgeons on the panel assess for presence of portal hypertension? And what are they asking for preoperatively for measuring?
Yeah, so for me, it's all radiographic based. So you're looking for, recanalization of the umbilical vein, splenomegaly, and then varices primarily. I think if there's any, sorry, go ahead.
I think in addition to the imaging, a lot of people have come to rely pretty heavily on the platelet count. This is a little difficult in the post-chemotherapy state, but I think a combination of the radiographic images as well as the platelet count. And then secondarily, I think if you need to measure pressures, particularly if you're going to get a biopsy anyway in a patient who's cirrhotic, that can help. I think those are really the main features.
I've just short question again. Dr. Winslow, you don't care about echography, you don't use it, you don't care about that, you don't have comparisons. Ultrasonography of the tumor, because I mean CT scan is an invasive procedure. You have to inject stuff, and which so ultrasonography is out.
I think for this is obviously a local regional thing depending on the expertise, but certainly contrast enhanced ultrasound is being used increasingly, I think, in the US, but not, I don't think, clearly for differentiation for transplant, right? So when it comes down to a major intervention, I think many people are still going to rely, not going to do a resection alone based on an ultrasound or decide to list somebody on that basis alone. But I think both the screening ultrasound as well as the contrast ultrasound has been incorporated more recently, but still into the LIRADs, because it is in fact, an international system.
Dr. Bari, I had a question about one of the patients that you presented. There was that one case, I think it was segment 8, it looked like a small little 2-centimeter HCC tumor. I think it's a great option in that patient to be able to do an anatomic resection. But what are your thoughts on sort of ablative therapies for a small tumor, especially someone with portal hypertension?
Yeah, it's definitely an option. Based on the guidelines, it's the recommended treatment for tumors less than 2 centimeters, and I think it's based on our current knowledge, it's equivalent in outcomes. But having said that, we don't know which tumors really, it's hard to predict the biology beforehand. So I think there's definitely a subgroup of patients, even with small tumors, who would benefit from an anatomic resection as opposed to an ablation. I think one way, or something that would probably put us in a better position to predict that, is a non-invasive way to predict microvascular invasion, which until now is really not possible. And I would expect that patients with known microvascular invasion, those will probably benefit from an anatomic resection as opposed to an ablation.
I was also interested when you described the R1 resection, vascular versus parenchymal. And I was to me actually when it's R1 with vascular, I actually would not have hypothesized as equivalent to R0 because for me, if it's adjacent to a vasculature, there's a higher chance of actually spreading through the vascular system. What are your thoughts on that?
Well, it's not infiltrating into the vessel, so it's it's essentially, at least that's the hypothesis or the theory behind it. It's a natural border, at least for HCCs. So the tumor does not reach the intima of the vessel. It's essentially attached to it, but it's not infiltrating and it's not inside the vasculature.
And the pathologists do they actually look at that, confirm that it's actually not?
The problem is, we're not taking them out, so it's hard to tell, for those where we actually did an R1 vascular resection, but it's probably a good idea to look at patients where you did an anatomic, let's say, right hepatectomy for a tumor adjacent to or attached to the right hepatic vein, and see if how many of these tumors actually infiltrate the vasculature. It's probably similar to the situation with pancreatic cancer where you do a portal vein resection. I think the majority of these patients, the tumor is not infiltrating into the vessel. It's not reaching the intima. It's essentially attached to it, but it's not infiltrated into the vessel, most of them. But there is a subgroup, and I think there are some pathological studies. There are patients with tumors infiltrating into the vessel, and those have worse outcomes and probably disseminated disease. But I think it's, what I really like about the idea is, breaking with old dogma that, we all grew up being told that, when you look at imaging and the tumor is attached to major vasculature, especially, hepatic outflow, that you have to do a major hepatectomy or, even anti-situ, ex-situ resections, to clear outflow. And you can probably prevent or avoid these massive operations by just, accepting an R1 resection, which, naturally we as surgeons don't like to see on the path report. But, as we say, biology is really more important than actual pathological reports. So I think some development in our way to look at these pathological reports and accept an R1 resection, knowing that you're probably not harming the patient. And using a laparoscopic or robotic approach really helps with this. You're not doing a huge laparotomy, you're not doing a huge operation to get an R1 resection. So putting all of this together, I think it's a new way to go for.
Are there any more questions? If not, I want to just end this webinar and just saying thank you for the wonderful talks. We are challenged in the dogma, as you can see from a lot of the presenters today, showing data that what was a dogma in the past, has to be actually validated with rigorous research. But I appreciate everyone's time and support for hepatoma research in this webinar. And once again, Victoria and your team, thank you for putting together this amazing webinar.